and also good afternoon, everybody. Although we left so far away, but with the help of internet, we can communicate free. This is the first time CUA Young Committee and North American Young Urologists changed something from the website, and I wish we can conduct such academic exchange more and more in future. And this time, we will talk about two topics. One is silent stone, and the second is what is the most challenging case in your practice. And so I think everybody can feel free. I just want to conduct a webinar which will let us to show something, to communicate something, and to learn something. And no false, no true after this webinar. Just your opinion, just show your opinion. So this is my purpose. This is the purpose of this program. First, may I introduce members from China? Professor Xu Kewei. He's from the Sun Yixin Memorial Hospital in Guangdong Province, South China. And he is also the Vice Director of CUA Young Committee. And Professor Xi Qilin, he's from, hello. He's from the first affiliate hospital of Suzhou University in middle part of China, beyond Shanghai city. And also Professor Li Ling, he's from Shanghai city. He now works in the Shanghai Hospital, Naval Medical University. And also Professor Wang Bohan. Is Wang Bohan here? I can't see him. Maybe minute later he will show. And Professor Wang Bohan is from the second affiliate hospital of Zhejiang University, beside Shanghai also. So these are members from China. So now, Professor Gutierrez, please show the members from US, from America. Thank you.
Yeah, so I'm Jorge Gutierrez. I am practicing at Wake Forest University in here in the United States. I think we have here Dr. Camacho is from Mexico. He practices in Monterrey, Mexico. It's a city in northeast of Mexico. He has a lot of experience doing flexible uteroscopy. And Dr. Who else is with us from North America? From UCI. Yeah, just remind me your name, please. I don't have the.
Yeah, first name Jam, last name is Okunov.
Oh yeah, sorry. Yeah, Sam.
Yeah, no problem.
Thank you. And he's practicing in you're in University of Carolina or California in Irvine, correct?
Correct.
That is one of the sites in US who has more experience in endourology. And I'm pretty sure that a lot of experience in stone disease and ureteroscopy, also percutaneous surgery. They have an innovative center for years, led initially by Dr. Clayman, now Dr. Jimmy Landman. So I think you have a very, 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 very strong group in endourology in that part of the country. So
thank you.
We follow you, Li Jung. What you want to do? I mean, we follow you. We follow your instructions, and we will comment very happily.
Thank you. So today, I and Professor Gutierrez will host the whole program, and maybe we will ask some questions and maybe we will interrupt the presentation. So just feel free, everybody. And the first topic today is silent stone. What will you do for silent stone? Treat or not treat? Oh, no, sorry. The first session will be the address for the meeting by Professor CUA. So he's a director, associate director of the Young Committee of CUA, and also is member of the Urologists group. Thank you, Professor Xu.
Good morning. Distinguished guests, colleagues, ladies and gentlemen, it's my greatest pleasure to welcome you all to the CUA Committee and North America Youth Urological Forum. I'm CUA Vice President of Sun Yat-sen Memorial Hospital, Sun Yat-sen University. As the Vice Chairman of CUA Youth Committee, I'm in complete honor to be present with all the out-of-state scholars and surgeons in and abroad. Especially the fact that all from overseas institutions attending this meeting serves to remind us just how important it is to join hands and promote global development of health and care in healthcare. Against a background of ever-changing medical technology, urinary cancers still remain one of the most common diseases in both developing and developed countries, posing serious threats to global health. Being the pioneer group in China, the CUA Youth Committee has stayed committed to improving medical treatments and exploring new technology in relevant areas. What's more, we launched a charity program for poor children living in remote rural areas. Up till now, 60 kids suffering from stone disease has been cured with free surgeries. Rewards had been paid, yet we need a pause to exchange and review. For classes of sorts were innovative ideas. By bringing together the speakers who are the best of the best, both at home and abroad, we are sure to spark new thinking and promote international collaboration. I would also like to take an opportunity to express my sincere thanks to Professor Li Jun of Beijing Fantasy Hospital and the honorable speakers. Without you, a grand event like this would not be possible. And my gratitude also goes to Zhuhai Pusheng Medical Technology Company, the sponsor of the conference, who has been working with us since the beginning. Hope we can turn today's event in a series of future activities and develop an international platform for cooperation and exchange. In closing, I hope that all of you will find today's conference informative and entertaining and enjoy the most of it. Thank you.
Oh, thank you, Professor Xu. Thank you for your thank you for the address for the meeting. And let's start the first section. Silent stone. This is some case, but not the case for today. We all know with the spread of the physical examination, we see more and more silent stone, just like this, lower pole, 1.5 centimeters, without hydronephrosis, no serious infection, maybe mild infection, and no pain, no blood urine, and also like this, both sides. So nowadays, silent stone become common and common. I remember when I first start my practice 20 years ago, most cases styrofoam stone. At that time, we shall use standard PCL to perform very hard operations. But nowadays, the size becomes smaller and smaller, and actually, most case in my clinic, it's not quite large stone and no serious complication. So, what will you do for silent stone? Of course, the stone may beyond the indication for ESWL, but maybe less than 2 centimeters. So what will you do? Treat or watch for waiting? So thank you, everybody. So everybody will show your opinion within 5 or 6 minutes, and then we will discuss the silent stone. Thank you. So the first will be Dr. Xi Qilin.
Defer.
Thank Professor Dr. Li's question about a symptomatic stone, observe or treat. First, we look at some data. Data one, this paper is published in BJU. The results shows for asymptomatic renal stones, the intervention rate was 12.3% at a follow-up. Diabetes and hyperuricemia was significant risk factors for stone growth. Stones size more than 5 millimeter and stones located in the upper or middle pelvis were more likely to become symptomatic. If obstruction is present, active treatment should be strongly recommended. Predictors of surgical intervention include stone size more than 5 millimeter and age more than 60 years. If patients with these identified risk factors should be recommended for longer term regular follow-up and or of the earlier active intervention. Data two, this paper compared asymptomatic renal stones smaller than 5 millimeter virus bigger than 5 millimeter. The result shows surgical intervention 31.9% at a median follow-up of 3.3 years. For surgical intervention for active treatment indication include stone size was not a significant factor. In multivariate analysis, age less than 50 years and a history of intervention for urinary stones were significant factors, but stone size was not. So this result is a lot different the above paper, about 20% of asymptomatic renal stones smaller than 5 millimeter require surgical treatment within 5 years. So this paper's result is different the first paper. Data 3, this paper is about asymptomatic kidney cell stone. The results shows 26.6% of patients proceeded to surgical intervention. Predictors of surgical intervention include patient aged younger than 50 years, stone growth more than 1 millimeter annually. So this paper's results also is different. The paper one. Paper one results shows the age also is the predictor, but more than 60 years old. Now we see 2020 year guideline. The indication for active stone removal renal stones. Stone size is bigger than 15 millimeter, but not 5 millimeter. EU guideline also shows that it is still debatable whether renal stones should be treated. Offer active treatment for renal stones in case of stone growth, the lower obstruction, associated infection, and acute and/or chronic pain. But stress rating is weak. It's not strong. So in my clinical experience for asymptomatic renal stones, if stone size is smaller than 5 millimeter, I can give patients some advice, including drink water, lifestyle advice, changing dietary habits. If stone size is between 5 and 10 millimeter, except for above advice, I give some give patients some suggestion, including follow-up periodically. Give patients take traditional Chinese medicine. Other advice include shockwave lithotripsy. If the size is from 10 to 50 millimeter, SW and RIS will be performed. This is my opinion. Thank you.
Can I ask a question? So can you explain us how do you follow the patients? The first question is stone less than 5 millimeters. You don't do any follow-up. You said in your slide that you follow with X-ray, or I want to know how patients who have stones between 5 and 10 millimeters. So the first question is, do you do any follow-up in patients who have stone less than 5 millimeters? Second question is, how do you follow them? Every 6 months, what do you do? KUB, ultrasound, CT, or what type of image study do you do? Do you understand the question?
Thank you for your question. If stone size is smaller than 5 millimeter, I think follow-up at 1 year.
And what is the method of follow-up? Do you do just simple X-ray? Do you do ultrasound? Or do you recommend CT as follow-up in patients on observation?
Ultrasound is the first choice at the follow-up duration.
Okay. Okay, if there is no other comment, I would like to hear the opinion of Cham Okunov. Cham, can you tell us how you manage your silent stones?
Sure. I've actually, if you could stop sharing your screen, I think I'm going to show a couple things. I think that was Dr. Schilling. That was an excellent summary. And can you hear me, Dr. Gutierrez?
Yes, I can. We can hear you very well. Yeah, yeah.
Okay,
Dr.
great.
Dr. Xi, can you stop the share of the
No,
screen?
no. I'm finished.
Yeah, you should stop sharing your screen so that he can present. You need to stop sharing your screen.
Yes.
Quit sharing screen.
OK。哟，这个怎么搞啊？共享屏幕退出来吗
Yes, quit sharing.
？OK。
退出共享。
Okay.
No?
OK, sorry.
No problem. Thank you very much. And I think that was an excellent summary. So Dr. Schilling kind of mentioned that he breaks down stone size less than 5 millimeters and more than 5 millimeters. And I'm curious to hear where that kind of threshold, maybe it's just his clinical experience, but I think from what the literature has shown and what our experience and my experience have shown is that we try to do it like less than 4 millimeters and, you know, anything 4 to 10 millimeters. And when I look at the, especially lower pole stones, I look at the anatomy, I look at the Hounsfield units, how dense is the stone. I look at the patient, if patient is asymptomatic or symptomatic, any history of urinary tract infections, and patient's preference. So those are the main factors that I would look into. Less than 4 millimeters asymptomatic lower pole stone, I would follow with a 6 months ultrasound and maybe annual, 6 months ultrasound, and then later on annually a CT just to see, make sure that the stone is not growing. And so those would be factors. And if it's and the patient patient prefers and he wants to get rid of the stone. Some patients get anxious. And the stone density is, I call them favorable factors. If the, I'll show you this slide I put together actually for this thing. So, we look at, this is in my mind, I look at the IPA, which is infundibular pelvic angle, infundibular width. I look at the CT very carefully, and then to see if a patient would be a good candidate for shockwave. And in general, these patients in lower pole, they're not ideal candidates for shockwave. And literature has shown that passing stone is equivalent to following that up to 5 years, and then the passing stones and treatment success in lower pole with shockwave is equivalent. I would, and then if stone density is low, and if it's less than 10 millimeters, I would consider uteroscopy, shockwave, or just observing, unless patient is very adamant about treating. And when that decision is made that we can actually treat it, so we have two options remaining, uteroscopy or shockwave. And then based on the stone density and anatomical approach, depending on the IPA angle and infundibular width, I would make a decision whether it's shockwave or uteroscopy. And a lot of patients, depending on if they had a history of treatment previously or not, they tend to pick either one. So if some of them failed previously shockwave, even the stone is favorable, they want to say like, no, I've done that before once or twice. I don't want to repeat it again. I just want to get rid of the stone. So obvious option would be, uroscopy. And if the patient is usually naive, this is initial treatment, they usually say, I'd like to try initially shockwave. And then if that, depending on the outcome, we'll go from there. But again, just to summarize, if it's smaller than 4 to 6 millimeters and it's totally asymptomatic, I would follow with 6 months ultrasound and maybe annually, maybe if the patient wants to do a CT to make sure that it's not growing. And if it's non-favorable, if it's a hard stone, and if it's large, I would go for more invasive treatment such as uroscopy or PCNL. And then I actually, there's plenty of data debating about the different treatments and patient outcomes, but just for the sake of the time, I'm not going to go over those data, but I'm happy to answer if there are any questions.
So, Cham, I'd like to ask you, so you say that stones between 4 and 6 millimeters, you may follow them with observation. What do you do with stones 10 millimeters? And what is your limit to follow a patient with observation? I mean, if you have a patient with 15 millimeters, you will suggest treatment. If you have a patient totally asymptomatic with a stone between 10 and 15 millimeters, you still recommend treatment, or what is your limit?
So the limit is if it's totally asymptomatic, there is no limit, right? So patient, for example, this past Wednesday, we had a patient with lower pole 1.5 centimeter stone, and he was totally asymptomatic, never had a UTI, and it was pretty hard stone, which was 1,400 Hounsfield units, which would not be a good candidate for, and it was non-obstructive stone. It was totally in the lower pole stone, non-obstructive, 1.5 centimeter stone, and patient said, listen, I know it's there, it's not bothering me, and if it's not killing my renal function, I don't want to touch it. So it's a very individual approach, right, Dr. Gutierrez? And then if there would be any history of UTI, I think my consideration of active surveillance would be, my threshold would be 1 centimeter. I think, the chances of increasing growing, obstructing the calyces, becoming symptomatic, and UTI increases with that kind of increase. And I would consider more treatment above 1 centimeter, given that patient wants that treatment.
Yeah, I could agree. I mean, I agree completely with you. I mean, probably our threshold is also 1 centimeter. Everything else above 1 centimeter probably start falling in the range of suggesting some treatment. But I think you're right. I mean, the decision should be individual for every patient, because I think one of the important things is to consider how is the status of the patient, the medical status of the patient. If this is a patient who has a high risk for anesthesia, high risk for surgery, and he has a stone, even if it's a little bit more than 10 millimeters, asymptomatic, we really don't treat them. We wait until they have some issues. And for us and those sick people with risk for surgery, the main indication will be infection. Whenever they start having infection, that's when we start planning a treatment. Otherwise, I will say, you need to consult with the patient, to discuss with the patient, and based on the status of the patient, you need to make a decision.
Yeah, and I think, I will quote Dr. Klayman. He says, like, if you have an asymptomatic patient, what's the worst you can do? It's like make him symptomatic and treat him and make him poor. So you don't want to do that. So if the patient is asymptomatic, if you touch him and try to try to treat him, only, the one thing you're going to do is make him poor, right? Pay for all the insurances. And so if it's not bothering him, and if there's no infection, and I just double,
But it's totally true. It's not only treating, the pain related with the treatment is that sometimes, if, for example, if you select for showy lithotripsy, then a stone that was laying very nicely in the lower pole now is going to be broken, and the stone may become symptomatic. So I'm fully agree with this statement. Yeah, that's.
So I'll show you one. I have one more slide I'm going to show you. This is from a study. So basically, for example, this one, This is a systematic review. Basically, 5 studies looking at lower pole stones, small stones, a group with treatment versus group with no treatment. And when the patients were just followed within, I think, 51 months, up to 30% of the patients, starting from 8% to 30%, almost 30% patients, they passed stones when it's lower pole and it's less than 6 millimeters. And if you want to treat them and they follow the same duration, within the same duration, these patients ended up receiving similar percentages of treatments, but so basically your question, do you need to intervene these patients or not? Because if you follow them, the probability of passing that stone, even given the complex anatomy and a location, it may pass. Its likelihood is low, but intervention level is as low as the passage percentages. So that's it.
Thank you.
Good.
Dr. Altnov, Dr. Altnov,
Yes.
can you hear me? I'm Dr.
Yes,
Lee.
I can hear you.
Yeah,
Hi, Dr. Lee.
I just heard you are sharing your experience because you're worried about some active treatments that will make their lower pole patient from systematic to symptomatic, right? And you talk about the anatomy of the lower pole calyx. Can you share your experience that how many cases? So what's the rates in your daily practice, in your daily work? Do you have the failure rate of the lower pole calyx by doing the flexible uroscopy? What's the rate? Yeah.
Shockwave lithotripsy, the failure rate for lower pole stone is extremely high. I think in our experience, I think it's above 70%, something like that failure rate. So, and then like the new machines we have here from Ladonia, it's been just challenging with shockwave. We don't even. I think we're just like it's. If there's some sort of like a long infundibulum and the angle is less than 70%, degree, I think shockwave is not. But uroscopy has higher success rate. I think it's about 80% success rate, which is comparable to PCNL, right? But uroscopy provides a lot of advantage because obviously you have less complication rates. So 85%, almost 90% success rate. And I think that's consistent with the literature. They're like, prospective randomized controlled trials for lower pole stones, less than 1 centimeter compared to, shockwave versus uroscopy versus PCNL have shown that uroscopy and PCNL have equivalent stone-free rates, but, uroscopy complication rate is lower, but OR time is higher. PCNL is obviously quick. You just get in and get it out, but a little more complications. And obviously for PCNL, you have longer hospital stay in the United States. That ends up to be a significant cost factor. I don't know about China, but uroscopy, you could do it, outpatient procedure. Now, like there's so much literature coming and showing that it's feasible. So those are the things that I usually keep in mind approaching these patients.
Okay, thank you.
Thank you. I have one question, maybe one question. Actually, my question is very easy. I don't want to talk about 5 millimeter stone. I don't think that's stone. Just watch for waiting. That's okay. So I want to talk about the case which step on the line, or a little bit beyond the indication, but without complication. So what will you do? Very simple question. Just like Professor Kucharis asked, the question from Professor Kucharis. 1 centimeter or 1 centimeter to 1.5 centimeter lower pole. So what will you do? Active or inactive? So this is my question. So we see a lot of patients like this. So maybe I will ask the opinion from the patient. Will you receive treatment or not? So I want to hear the voice from the doctors from China or outside China. So this is my question. Thank you. So the next speaker will be Dr. Wang Bohan. He will show his opinion. Thank you.
Good morning, everyone. My name is Wang Bohan from Second Affiliated Hospital of Zhejiang University. Today's topic is a systematic stone observe or treat. So for this topic, I checked the literatures. So I found the prevalence of a systematic stone is about 8 to 10%, and the optimum management for a systematic stone is still unknown. So for the natural history for a systematic stone, the incidence of the systematic stone, in fact, is between 13 to 32%, and the spontaneous passage is between 13 to 20%. The size increase is between 30 to 48%, and the intervention is 7 to 26%. This research published in Journal of Urology, the natural history of non-obstructing asystematic renal stones. They are followed by active surveillance. So they conclude that among asystematic non-obstructing renal calculi, they use active surveillance. The only significant predictor of spontaneous passage was the location of the stone. This research published in BGU International. The natural history of a systematic renal stone rarely requires intervention. If the size of the stone larger than 5 centimeters, diabetes, hyperuricemia, or non-lower calyceal stones are at high risk. This research is about a systematic renal stones to treat or not to treat. The treatment decision for a systematic stone should take into consideration by the factors for the patient and the stone. And under appropriate consult patient, active surveillance might be appropriate for these patients. So the AOA guidelines for patients with a systematic non-obstructing calyceal stones, active surveillance is recommended for these patients. Also for EAO guidelines, we can see that conservative treatment for small asystematic stones and under close surveillance is recommended for these patients. So there are also some high-risk factors for these stones to become systematic. For the stone characteristics, we can see first location. If the stone located in the renal pelvis and upper pole, middle pole stones, they are likely to become systematic. And the size, if the size is larger than 5 centimeters, it will become more likely to be systematic. And for the patient's characteristics, if they have sedentary kidney, diabetes, immunodeficiency, children, high risk occupation, just like airline pilots, military, or patients, or poor access to medical care for these patients, I think more active treatment is needed for these patients. So in conclusion, active surveillance is recommended for systematic non-obstructing renal stones, and the active treatment is needed with people with high risk factors. So that's all. Thank you.
Thank you. So what's your opinion? Treat or not treat?
Treat, I think active surveillance.
Yeah, if common people, not child, not adult, not army.
Yeah, for common people with a systematic non-obstructing stone, I think active surveillance is recommended for these patients.
Thank you.
But the patients with high risk factors, just like the stone size, the stone location in the upper or middle pole, or the size is larger than 5 millimeter, or the patients with many characteristics of high risk, I think more active treatment is needed for these patients.
So for most silent stone located in upper pole, I think it will be diverticulum stone, actually.
Yeah, yeah.
If for most case. So actually, so if for such case, which kind of instrument you will use?
If the stone size is more than 6,
I mean, silent stone and maybe, but you are not sure. Maybe diverticulum, maybe not. So, if you want treat, you want to which kind of instrument or which kind of operation you will use for such case?
For the detection of the stone, I use ultrasound. This is the first choice. And for the treatment, I think ESWL is the first treatment for upper pole stone.
Upper.
Yeah, upper pole. Yeah, ESWL.
But if
diverticular.
if we diagnose diverticular.
Excuse me.
If the stone located inside the diverticular, so will you still use?
No, I use uroscopy, flexible uroscopy. If the stone size is not so large, I use flexible uroscopy.
So I want everybody raise hand. So if a diverticular stone, please raise hand. Diverticular stone.
Well, for the upper pole,
I would like to comment something.
1.5.
I never do a treatment. If I decided to do a treatment, I never make the decision without a CT. So for follow-up patients, when we decide and the patient agreed to do observation for non-symptomatic stone, we can do as all of us have been saying with ultrasound. And I do ultrasound and simple X-ray the day of the follow-up, which is every 6 months or even 1 year. But when the patient start showing interest for being treated or start having any type of symptom, I do a CT. And that's what will answer your question. Then you can see if this is a diverticular or not. And I will be agree, if this is a diverticular, I will not do Shawili to Tripsy. Even if it's in the upper pole, you need to do endoscopic treatment, either flexible ureteroscopy or even a mini perk direct to the diverticular. But yeah, I mean, my point is that I never do a treatment just with ultrasound. If I'm going to do a treatment, I'll do a CT. Whatever treatment I decide.
Yes, we must perform operation before. We must perform CT scan before operation. This must be. So, how to diagnose a diverticular? But for some cases, it's very easy. We can see the cyst and beyond the systems beyond outside the collection system, so we can diagnose diverticular. But for some cases, the structure is not quite clear. So, but if the stone 1 or 2 centimeters just locate in upper pole, if the structure is not quite clear, but I in my experience, I think this for most cases will be diverticular stone.
Yeah, that's right. If not a diverticula, what is sure is that if probably not a diverticula, but it will be a narrow infundibulum. This is for sure. A stone that never moved from the upper pole has a narrow infundibulum. Probably not a diverticula itself. It's not a sac. It's the calyx, but with a very narrow infundibulum communicating to the rest of the collecting system. And for practical purposes, it's the same. If you do show lithotripsy, it's not going to be successful. So I think ureteroscopy or percutaneous surgery using a mini perc access will be, for me, the treatment to go. But I'm agree. I mean, upper pole, stones, never move. Something must be wrong with the infundibulum.
Yeah, yeah.
I totally agree. I totally agree.
Yeah, that's right.
Actually, for diverticular, I would rather choose, no matter how large the stone or how small the stone, I would rather choose PCNL instead of flexural-uroscopy.
PCNL?
Yeah, yeah.
Mini PCNL.
Yeah.
Yeah, I mean, I think especially coming from China, this is a world highest experience of mini PCNL. So I'm pretty sure most of you favor mini PCNL. But I think we need to consider also the location. If you're going to have to do a very, very high access to the kidney because it's the left kidney and the kidney or the diverticula is above the 11th rib, probably is not a bad idea to do a flexible ureteroscopy. It's going to be less risk, you know.
But Professor Lee?
Yeah.
Professor Lee, in most cases, you prefer PNL to flexible uroscopy if the stone located at the upper pole, but would you consider for the flexible uroscopy if their stone may be located in the abdominal calyx of the upper pole, not the dorsal?
Also, I choose this.
Even if it's abdominal calyx?
Yes, yes.
Okay, okay.
I performed some case just a few years ago. So, in my opinion, if diverticular, if common people never perform operation, in my opinion, because no complications. If the patient want to treat the diverticular stone, normally he is not common people. Maybe have a joint army, maybe pilot, maybe he has some special demand for the treatment. So we must totally clear the stone. No fragment left. So for such people, if you use FUS, I don't think the stone-free rate is 100%. I don't think. First, you should let all the stone fragment outside the diverticular and inside the collection system. But I performed some FUS before. The result is not quite good. The patient is not satisfied with the result. So this is my opinion. If treat, just totally clear, or left the stone. So this is my opinion. So.
Okay, Li Jun, why don't we hear Victor Camacho, what he has to say us? Is that okay?
Yeah, thank you.
Can we hear Victor? Victor, tell us, what do you think about silent stones? Victor?
Yes. Hi.
I think we cannot see you.
No? Okay, perfect. Yeah.
Now, yeah, okay.
Yeah, hi. Well, I'm Victor Camacho from Monterrey, Mexico. First of all, I would like to thank invitation for to Pusen Medical to this webinar and have the opportunity to share with us this case. I share my screen. It's a 52-year-old male went to the emergency room department at Mexican Institute of Social Security with classic pain symptoms of a ureteric colic. A Mexican Institute of Social Security is the biggest public hospital in Mexico. 2 weeks ago, he lost his job because of the pandemic quarantine. And well, the workers in Mexico have only 3 months more of the public medical insurance after they have lost their job. This factor was very important for us to make decisions for the clinical patient care. Then this is the CT scan. We identify a distal ureteric calculus in the right side. And in the left side, we observe the upper calyx stone of 6 millimeters. We proceed to the patient with a rigid, semi-rigid laser ureterolithotripsy and bilateral ureteral stent placement. We decide to place a ureteral stent in the left side to facilitate the access and avoid the risk of the complication during the left flexible ureteroscopy. 2 weeks later, we remove ureteral stents and the left flexible ureteroscope weight indicate to remove the upper calyx stones. The patient now is free of stones. We decide to present this case as a process of treatment of asymptomatic kidney stones because the situation, the economic problem in Mexico for the COVID-19. In our patient, the current social situation and economic factor was important to make decisions or treatment and give him the possibility to continue his life normally. This is my case. I present that because you said that it's important to individualize the patients and the treatment for the situation, special situations.
Let me ask you something, Victor.
Yes.
If the social issue was not a problem for this patient, and he has a stone not in the lower pole, which is in the upper pole or in the mid pole, asymptomatic, what will be your decision? Not thinking about the social issue, which is, I understand, is very clear because the patient will lost the insurance. So now he's insured and you want to clean the kidney. But if it was not an issue, the social problem, how will you treat this asymptomatic stone, not in the lower pole, in the mid pole?
In the mid pole, maybe it's only observational with ultrasound or simple KF rate if it's possible of the density of the stones. It's my opinion.
And I would like to hear the opinion of the rest here because we have been debating on the lower pole stones. What do you think on asymptomatic stones in the mid pole? What will you do, Cham, first?
For mid pole, obviously, I think the point that what your discussions that you made for upper pole being, if the stone doesn't go this narrow, I think it makes sense to divide. Oh, somebody. It makes sense to do. Yeah, somebody needs to mute the mic. I think, my approach in my mind is lower pole versus everything else, right? When it comes to, applying shockwave, I think lower pole, anything besides lower pole, success rate goes significantly higher. Mid pole, providing S-well would be about 60%. Which is significant success rate, which is significantly better than a lower pole in the mid pole. The same thing with the uroscopy and PCNL. I think uroscopy and PCNL would depend on the size and whether it's caliceal, diverticulum, or depending on the angle of on the anatomy and patient preference. I think with the development of the technology and so much flexible uteroscopes. Now lasers are coming out. Now we have access sheets that we can put up like a 14 or 16 size access sheet, right? You can, if anywhere in the kidney, you can get out up to 1.5, 1.7 centimeter stones. You can comfortably do uteroscopy and get them out. So again, as we talked about the lower pole, it's very individual approach. And given the density of the stone, skin to stone distance, you know, if it's obviously obese patient, PCNL is going to be very complicated with, you know, significant morbidity. I think those patients would be better candidates for uteroscopy. And same with shockwave, anything above 10, you're going to miserable fail, you know, it doesn't matter. And I've seen some patients come in from private practice communities. Some people do shockwave for stack or stone. Why would you even consider doing that? So individual approach, again, the same anatomical stone characteristics, patient characteristics, and very important is patient's preference, what they prefer. You know, when it comes to uroscopy versus PCNL, something within a reasonable size, I think patients needs to be informed and they need to be involved in decision making. It has to be shared decision making to make sure that you know, we're providing the optimal treatment.
I would like to hear the opinion of Li Yun and all the friends from China. Do you change the approach of observation if the stone is not in the lower pole, or you still give a chance somebody with a stone at the middle pole between 5 and 10 millimeters for observation if it's asymptomatic? What would you do, Dr. Lin?
You mean middle pole? Middle pole.
Yeah, middle pole.
Symptomatic.
As the one that Victor presented, you know?
Less than 1 centimeter.
Yeah.
Yeah, middle pole. Less than 1 centimeter.
Observation or treat? Asymptomatic.
Actually, if this is a common people, no special demand, I think just watch for waiting. I will let the patient come to my clinic maybe each 3 months and just perform ultrasound.
Any other opinion, Dr. Lin?
Me? Yeah.
Yeah.
If the stone is less than 1 centimeter, but larger than 5 millimeter in the middle pole or in the upper pole, I would suggest a patient to take an flexible uroscopy because, well, flexible uroscopy in China could be a, well, out hospital procedure, and we can perform the flexible uroscopy in the morning, and the patient can go back to home in the afternoon. So it won't take so much time. And for these patients, I would have a 80% or 90% to have a 100% stone-free rates. So if the patient comes to the clinic, I think he wants to have a stone clearance treatment. So yes.
You will not treat this patient with observation.
If the stone is less than 5 millimeter, I will recommend the patient to go back to home and to have some observation, active surveillance. But if it is larger than 5 millimeter, as you can see later, I will show you in the PPT slide, these patients would have some symptoms when their stone is passing out. So for this patient, the stone is still in the middle pole, larger than 5 millimeter and less than 1 centimeter. I will recommend him to take a flexible uroscopy. Yes.
You place a stent before some days before to do a flexible ureteroscopy?
You mean if I would place the stent before the surgery?
Yes.
Oh no. Maybe 5 years or 6 years before, we used the pre-stent to for the preparation. But as you can see, for nowadays, the flexible uroscopy, the uroscope is very thin, and the sheath, the US is very smooth. Even the patient's urethra is not so large. For 95% patients, we can place their sheaths with succession. Yeah.
And after the procedure, you place a stent or not?
Yes, I place a stent. Mostly I prefer I place a 6 French stent for 2 weeks. Yeah. If the patient is a female patient, I will leave their wire I will still leave the wire so the patient can remove their stent when they go back to home. Yeah,
Okay.
the wire is outside the urethra. Mhm.
But actually,
I'm curious about does everybody use access sheet for uteroscopy universally? Like everybody?
100% in my center, access sheets.
I don't do. I mean, sorry. Go ahead.
Yeah, but actually, I present 100% in my center, and access sheets 100%, and after operation stent 100%.
Oh,
So
that's very meticulous approach.
I know I never do this. I actually just to do access sheet in case that we're going to remove a lot of. I mean, we're going to go in and out from the kidney to the bladder more than 5 times. And nowadays, what we're doing, I favor a lot the dusting procedure. So dusting is my favorite thing to do. So I just dust all the stone as much as I can, and at the end I take a small sample for composition analysis. But if I can, I just dust the stone completely, and I try to avoid access sheet. Access sheet will be only in case that, again, it's a hard stone that you cannot dust and you have to remove fragments, then we use an access sheet. And we never stand the patient before that. Now, you and Sham come from the school in the world that favors a lot the alpha blockers before the ureteroscopy to dilate the ureter, and it's amazing the results that you have. I think nobody else in the world has proved that is Flomax or Secotex in other parts of the world, or tamsulosin dilate so much the ureter. But I think this is a routine practice in Irving. Is that right? Still a routine practice. How many weeks ahead of the ureteroscopy you do tamsulosin? 2 weeks ahead?
Tamsulosin 1 week.
1 week.
1 week.
And you report that you have seen increased facility to advance the access sheet or the ureteroscope. Is that right?
Yeah. So we 1 week. So we published actually data, and there's more publications coming up. With 1 week tamsulosin, there's 40% increase from placing 14 access sheet to 16. So there's a 40% increase being able to put 16 size access sheet.
Yeah.
So, Dr. Zhang, you think also Dr. George, you think alpha blocker works for dilation of the ureter? So, is there any?
I believe so.
Any paper support this? So, can you give me some papers about this? Actually, in my
Yes,
center,
I can. After the thing, I can send you some our data. We have some data from an institution.
So, yeah,
It's prospective randomized trial.
I try to find some documents about this because in my center I have to present 100% to avoid the injury of the ureter. So if one case injury of ureter, that might be very serious in China. So if something support this, maybe I will use alpha blocker instead of present in future. Mm-hmm. Thank you. So the next will be Dr.
Yeah, thank you. But one more question for Dr. Oknov, okay? Yeah, I just heard. Yeah, you also use the access sheets for the uroscopy, right? So which access sheets would you prefer? We have a 9.5, 11.5 French access sheets, 12, 14 French, 13, 15 French, 14, 16 French. Which one would you prefer?
The bigger is better. We start with 16. And if we can pass 16, we go down to 14.
Okay, sure.
This is big.
So if
this is big.
What's that?
That is
only
really
with the preparation for the tamsulosin, you can put a 16 French access sheet.
Yes. Also, I think
amazing.
Well, yeah. Hey, Dr. Gutierrez, go big or go home. But But with, as I said, with the tamsulosin or with pre-stenting, your ability to put a 16 sheath without those tamsulosin or pre-stenting is 60%, 40% higher with 16 French, but 14 French. And we have a device. This is Dr. Kleiman's invention, which is called force sensor. So we have a device that we attach on the access sheath, and we will put it. Device makes a noise, and it's there's a green button and red button, and if that button turns red, you don't have to push it harder because you're going to rip the ureter. If you go about 4 newtons of pushing, 4 newtons, your ureter will rip. So if we start with 16, we use the measuring device, and if it doesn't go up, we're not going to push it, and we go down to 14 and it goes up.
And then
so if you use tamsulosin, or stenting, that force is significantly less with 16 and 14. So it's science. It's not something that I made up.
So if you cannot use the 16, you open the 14 and not the 12. This is a rich institution. You open a lot of things for kids.
So
you have a lot of money.
We are.
Yeah. So when would you show this amazing device to us for calculating the force?
I'll show it. Somebody needs to mute.
But Dr. Zhang, you know, the 7.5 French fluoroscopy will appear soon from Pusen. So at that time, I think 14 French will not be necessary. Maybe 12 enough for 7 French scope.
Yeah. Oh, bigger. You have more space. You have better stones you can remove. So that's the idea.
Mm-hmm. So I'm
trying to find the picture of the device so I can show it to you. Here we go.
Thank you. So the devices feel pressure or something. So the device you use feel pressure from the ureter or something.
Yes. So do you see my screen?
Yeah.
Clear.
So this is the device. This is like a prototype that we made in the lab. We built it with our engineers, but now we made it, better version. There's like a more ergonomic looking, more professionally done. This is turn on. This is a light, and this is like goes up and down. So all the way up, it's green. Oh no, it's green here, and if you go, pressure goes all the way, it turns red, and this turns red and it makes noise. And you attach your access sheet right here, and when you push it, you will see the pressure right here, and it will automatically tell you how much pressure you're applying. So if you're applying too much pressure, this will turn red, and this machine makes noise, and it will stop you from pushing the access sheet, because if you go above 4 newtons, you will rip the ureter. So
amazing.
If you have a patient with who you pre-stented or you gave a tamsulosin for a week or 2, and you want to put up a 14 sheath access sheath, and you're putting up, and the machine doesn't tell you you're in red zone, you can put it up, no problem. If you put up 16 and the machine doesn't tell you you're putting too much force and it's going up, put it up 16 and enjoy the procedure. You can remove bigger stones, your irrigation is better. So that's the idea. But if you even have a 11 size access sheet and the machine is telling don't force it, you can't put it up. So that's why this is science. So this is there is data which is coming out in the near future. We could do another webinar, Dr. Lee.
Yeah. I will conduct another webinar just for the device.
Just for the device. Yeah.
Thank you very much. And I wish the device come to China soon, so we can push the access sheet is safe and free.
Yeah.
Thank you.
Yeah.
Next one must be Lilin. He's waiting for a long time. Thank you.
Okay. Share my screen. Okay.
Just not to interrupt you, but I think we have another expert who is Dr. Zach. We haven't heard from him. Maybe we'll, maybe he can say a word and say what he thinks. Can you
Sorry,
hear us?
I'm the North American manager for Pusen. I'm just running interference to make sure the webinar goes well.
I see. Okay,
Sorry.
Thank you for your support.
Sorry to interrupt.
Yeah, he is for help.
So can you see my screen? There a symptomatic stone observable treat. Can you see my screen?
Yes.
Okay, thank you
Yeah.
everybody. Thank you, Dr. Lee, Dr. Xu, Dr. Ogner, yeah, Dr. Gutierrez, and the other guys. Well, I was given this topic, the symptomatic stone observable treat. I think to figure out this problem, I draw a picture. I think we should, for my opinion, I will follow this direction. So what is the symptomatic stone? So what is the silent stone? So what is the prevalence and what is the progression? If the progression goes to bad, I think we need a surgical intervention. If the progression is relatively good, we could have a active surveillance. And if we want to do some intervention, we should compare the stone-free rate, the risk, and the cost of all these treatments. So the first one, the definition of the silent stone. I reviewed the literatures, but and the guidelines, but I haven't seen any clear definition of the silent stone or the asymptomatic stone. But I can conclude some issues. I think there are three important issues. The first one, it should be non-obstructive. It means, as you can see, no hydronephrosis, no calyx obstruction. And the second one, the patient should have no symptom, including their hematuria, pain, infection, deterioration in renal function. And the third one, maybe the most important, the stone should be very small. But how to define small? Less than 5 millimeter or 5 to 10 millimeter, or larger than less than 15 millimeter. There's no evidence. So I think the second one, how much is the stone, the silent stone, is still not clear. So the second one, the prevalence of the silent stone. I reviewed the guidelines, CUA guideline, AOE guideline, and some literatures. I found that the prevalence of the silent stone is about 7.8%. Well, it's almost equal to the prevalence of the stone disease. In America, it is 8.8%. In China, it is 6.4%. And the average patient's stone number is about 2.1, and the cumulative stone size is about 10 millimeter. As you can see, most patients have multiple silent stones, so the cumulative stone size is not very small. You can see from the literature is even larger than 1 centimeter. And the stone location, you can see most of the silent stone is located at the lower pole of the collecting system. The third one is the progression. So what is the progression of the silent stone? Is it going to bad, or it would be good for a long time? As you can see in the EU guidelines, here it says the natural history of small non-obstructive asymptomatic calculi is not well defined, and the risk of progression is unclear. So it's still unclear. So I still remember I did some literature review, and this is the literature published in the past few decades. You can see this is the progression. The patient would go from symptomatic to symptomatic is about 10 to 20% every year. And the 5-year event cumulative rate is about 48%. It's almost a half of the patient will have their symptoms. And the requirements for the surgical treatment ranging from 11% to 40%. And you can see no matter it is lower pole or a non-lower pole patient, the surgical requirements are almost the same. And the stone progression from small stone to larger stone from the literature published is about 32% to 77%. So it means half or even more than half of the patient's stone is going to be bigger during their observation time. And the spontaneous passage is about 12 to 30%. And you can see that it has a relatively low spontaneous passage if the stone located at the lower pole. Also, we have some risk factors in the published literature that investigating their stone-related events risk factors. If the patient age is less than 50 years, the stone grows faster than 1 millimeter every year. Well, male patient, smaller stone, and have stone history, it would have a relatively high stone-related events during the active surveillance. This is the cumulative incidence of the symptomatic stone events. You can see that if the stone burden is higher, it would have a higher stone-related events rates. This one is almost the same. So this is another literature published in 2017 from China. Dr. Zheng Guohua is a very famous stone expert in Guangzhou. He made an risk factor in analysis. It says the stone size, if it is larger than 5 millimeter, it would have a higher risk for their stone progression. So this is the progression of their symptomatic stone. So from the EU guidelines, we can see that conservative treatment for a small asymptomatic stone is only possible. Yes, it is feasible, but only possible under close surveillance and in absolutely compliant patients. So still, you can see that the evidence level is not very high. So we just know their progression for the stone. The next time, if it's good, we can use the observation. If it's bad, we use surgical intervention. So what is the observation? So what is the patient choice? This is the data from the paper published in Journal Urology, Journal of Urology 2013. You can see that 56. We can see that if the patient has no previous stone experience, most of the patients would choose a observation. But if the patients have some medical, some surgical treatment before, even no matter it is PNL, no matter it is flexible uroscopy, the majority of the patients would choose surgical treatment. You can see that if the patient have a UAS or a US, can see that most of the patients would have UAS. Most patients would have the shockwave lithotripsy. Not very people choose the observation. But another very interesting thing is that 56% of the patient deferred the decision to the treatment to the physician. So what is the physician's choice? Just now we all discussed our choice, our opinion of their silent stone. But you can see that this is a web-based survey for 149 urologists. So what's your choice for the silent stone? You can see that we don't. This is for children. We see the adult patients. Only 52 urologists would choose a observation, and you can see that shockwave lithotripsy, PNL, IRs, these three parts of the surgical treatment, almost a half of the urologists will choose. Yes. So what can we benefit from active surveillance? This is the benefit we can get from the active surveillance. You can see that the stone-free rates for active surveillance is about 30%, less than 30%, but we would have a related events, maybe almost 50%, including pain, infection, hematuria, surgical requirements, and we would have a price, just as the doctor Gutierrez said, we would have a CT scan every 6 months. Maybe we should have a metabolic evaluation, dietary modification, and medical therapy. So active surveillance, I think it costs not very small, not very little. So what can we benefit from shockwave lithotripsy? This is the literature published in 2001. You can see that the stone-free rate for shockwave lithotripsy is higher than the active surveillance, which means shockwave lithotripsy would have a better stone clearance, better than observation. And this is the three-armed prospective randomized control trial compared PNL, shockwave lithotripsy, and observation for the silent stone. You can see that PNL would have a almost better than 95% of the stone clearance at 3 months follow-up. So, but you can see that the observation, the stone clearance is not very satisfactory. So what about flexible uroscopy for the silent stone? This is another paper published in 2015. You can see that the flexible uroscopy, the stone-free rate at 3 months is 92%, which is much better than the observation and almost same to the shockwave lithotripsy. So here's my summary. If we conduct an active surveillance to the silent stone, we would have a high risk of stone progression, and the patient would have maybe a very high risk to have some symptoms and require further surgical treatment. And the spontaneous passage is relatively low, especially for the lower pole stones. And in nowadays, as the flexible uroscopy industry and the equipment are getting better and better, flexible uroscopy and PNL achieve satisfactory results and would have very little surgical complications. So I think, certainly from my opinion, the treatment strategy for the asymptomatic stones could be, well, more aggressive, or you can say less conservative. I think even the stone is larger than 7 millimeter, I would have a surgical treatment. Yeah, that's all for my opinion. Thank you to all the people.
Yeah.
That was a very good presentation, a very good summary, very nice presentation.
Well, thank you, Dr.
To summarize what we have been discussing, I would probably, add to your presentation or remark, if you will, that stone events may happen up in 70%, between 35 to 70%, if we include pain and visit to emergency room and infection. But intervention is between 10 and 25% of the cases, even after 5 years. So again, I think the point here is to consult with the patient, to discuss with the patient, see what the patient wants to do. And my personal experience, we have a lot of patients with silent stones that we follow in observation. And most of these patients are patients that had been treated in the past, and they know exactly what is going to happen. They know that if they start having pain, they will call us and they will request for immediate attention. But they know also that it may be 1 year or 2 years until the next event or the next time they have any indication to do an urgent thing. They also know that at some point they will have to visit the emergency room. But they, again, people who have had a stone event in the past, and most frequently people who have had more than one stone, these are the people who usually elect for observation. And my final comment will be, think on the patient. There are sick people who the risk of doing the surgery in a silent stone is much bigger than do the treatment. So, I mean, it's much bigger the risk of doing the treatment compared to observation in a sick patient where the chances to have a final intervention is less than 25% in 5 years. So.
Well, thank you, Dr. Gutierrez.
I think so. Each member show their own opinion, but no right or no wrong. So, but each doctor will treat the silent stone with his own obviously routine procedures. Maybe in future we can get some guidelines or something and to tell us how to treat with silent stone. Actually, nowadays silent stone become more and more. I think this is the result of routine physical examination. I think in future maybe siphon is a rare case, but silent stone will be the main things in our clinic. So, anybody has anything to talk about for this topic, silent stone?
We have covered it extensively.
If so, I think it's already 1.5 hours from the start. So let's start with the second topic. So please show the most challenging cases in your experience. So the first will be Dr. Xi, please.
Thank you. Hello. Now reporting my most challenging case. The patient is female, 50 years old. Her main symptom is no flank pain for 3 years. She performs. She do about 5 treatment progress in 4 years. The first surgery was performed in 2016. She do bilateral PCL because of bilateral kidney stone. The second surgery was performed in 2019 because she felt always left her back pain. So bilateral uroscopy surgery was performed. At follow-up, she had residual stones in bilateral kidney. 2020 years, CTU's examination showed multiple low-density lesions in upper pole of left kidney, and the compression change of left pelvis and kidneys. The QB shows she had radial stones in bilateral kidney. CTU examination, multiple low density lesions of the upper pole of left kidney. So the diagnosis is renal cyst or left renal hydronephrosis. In different hospitals, these two diagnoses so I consider the left kidney nephrosis is possible because of upper kidney neck closing. So I performed laparoscopic partial nephrectomy in 2020 years. During surgery, flexible uroscopy examination did not found passage into the upper hydronephrosis. After surgery, this patient have had a recurrent fever and left low back pain. Then we performed left perirenal puncture, the drainage, on the guidance of ultrasound, because the drainage volume is about 300 milliliter. So in 2020 April, I do the final surgery on the flexible uroscopy. I incise the upper kidney lect and place stent into upper kidneys, upper kidneys. The final surgery was performed to collect the collecting system with the upper residue cavity, and a stent tube was placed for internal drainage. But in the operation day, after 6 hours after operation, this patient have a high fever. The diagnosis is considered urosepsis. Blood pressure is very low. Peripheral blood leukocytes are going to be very low. Other parameters is very serious. So I think she has septic shock. The possible reason may be associated with large amount irrigation and high pressure with the pelvis and kidney during operation. In this operation day, this patient was transferred to ICU to continue treatment. 3 days, this patient is this patient become the infection was controlled, so she became good. The fung liver and the kidney returned to normal, and CT showed with absorption of perirenal fluid. Then the stent was placed for months. Ultrasound scan did not find abnormal perirenal. So just 2 weeks ago, the stent was removed. Now this patient have low discomfortable size. Thank you. That's all.
So thank you, Professor Qi. So I think this is a serious infection after endoscopy operation. Is that?
Yeah.
Okay.
This patient do very operations, about five surgery, because the kidney stone, but the diagnosis is very difficult, especially for left kidney. Upper pole is cyst disease or hypernephrosis. So the treatment is suitable for her is the question.
So we don't see the video for the operation. You don't show the video. So so you open the neck finally. So you open the neck of the upper calyces finally. This endoscopy technique.
Yeah.
Sorry, I think it's very difficult if the total obstruction of the neck, you will incise, and also you will avoid the vessels.
Because after laparoscopy, partial laparotomy, this patient have renal leakage, fluid leakage about every day about 300 milliliter. So this is maybe this is a complication. So the final operation is performed to solve the complication. So we use flexible uroscopy, use laser to incise the upper kidney's neck closing, and establish a passage upper kidneys into renal pelvis. 4 months. Now this patient maybe good.
I wonder the long-term result.
About 3 weeks. So at full off.
So will you tell me the final result? Maybe 1 year, maybe 2 years. So
yeah.
This is most challenging case. Thank you.
Clam, do you have a case?
Do have case?
You're muted.
Oh, if you guys have a case, that would be great if we can discuss. I prepared the lower pole discussion, but I didn't have a case to present.
Let's go for the next. Who else have a case from from you guys?
Yeah.
Okay, go, Dr. Link.
Yeah. Okay. My turn. Okay. Share my screen. You guys see my screen?
Yes.
Okay. I'm sorry. Okay. I skipped the most challenging case because a lot of cases challenging, a lot of cases nightmare. So I just picked the one case, a challenging case. This is the case, a male patient, 67 years old, with left chronic pain. Come to
Can
my
you make the
hospital.
screen bigger? Can you make the presentation screen?
Yeah, I'm sharing my screen. Can you see that?
We see all the slides. So why don't you make us?
You mean this one?
Make the slides bigger.
You mean make the slides bigger? Well, the slides is in my PPT.
No,
so.
we see all the slides here, but we don't see this bigger. You see? Why don't you do the screen presentation?
Full screen. You use the full screen.
No, it's still not full size. Okay, I will see
No,
full screen. Yeah,
yeah, not full screen.
Oh, okay. You mean the slides? Oh,
Yeah.
the slides. Well, I put the slide in as PPT.
Okay, that is
sorry,
better.
Sorry,
Good.
sorry. Sorry. Yeah, sharing this screen again. Okay, this is the small stack on stones on the left side. He has an open surgery history for stone treatment 20 years ago. This is the pre-KUB. This is the pre-CT scan. You can see that the stone burden is relatively large, and the lower pole of the kidney, well, it's not very good. The nephrosis is not very big. For these patients, we think the stone is very big. We conducted a PNNL for the treatment. You can see that this is a tract planning for the patient. You can see that we have a dorsal calyx here. So we plan the track to put the puncture here. Well, this is the ultrasound guided puncture, and maybe someone would ask, why would have a ultrasound view and the out view together? Because this is actually it is a live broadcasting for the patients. We are having a conference, so we have both of the ultrasound video and the surgery video together. You can see that. The doctor do the puncture here. This is the stone, and this is the needle. This is the needle. I can see that it seems that the tip of the needle touched the stone, but when he remove the core, there's no urine comes out. But the doctor still performed the second procedure, which is the balloon dilate of the tract. You can see that when he finished the dilator.
We don't see that. You're not moving this now. Okay.
No,
Yeah.
you can see that? He
No,
did the puncture.
Move it. Move
Okay.
forward. Now.
You can see he put the scope into the sheath. You can see the irrigation is quite not clear. There seems to be a lot of bleeding. This is the tissue. This is a fat tissue. Obviously, he lost his track, but the guide wire is still there. You can see that the irrigation is quite red, so he lost his tract. But you can see I picked some picture of the video. It seems to be the guide wire is still in the collecting system. This is the guide wire. Is this the collecting system? I'm not sure. He's not sure. So the doctor relocating the sheath into this part of the structure. It seems to be the collecting system. When he moved the sheath into the this kind of the structure, the bleeding is even severe You can see, you almost can't see anything of this part. And the irrigation here, it is almost the blood, and it seems to be very warm, so it is severe bleeding. So what's wrong with this procedure? Did he lost his puncture? Continually, he searching the stone, he's searching the collecting system. You can see that it seems to be the lumen of the collecting system, but it seems to be some branches. So we have the lumen, we have the branches of the, well, the collecting system. Is this the collecting system? Where is the stone? We found the branches. Seems to be the branches. Here, we found the branches. No, it is not the collecting system, it's the renal vein system. Yeah, he suddenly, when he figured out this problem, he withdrew the sheath, do some compression, and perform the ultrasound examination again. Well, fortunately, there's no hematoma around the kidney, and the urine outside the catheter. It is, well, it is not very red, so we do the puncture again and finish the surgery. This is the pre-CT scan of the kidney. This is the first procedure of the kidney. You can see that this is the catheter. This is the catheter. Although the stone is not clear 100%, but at least we do the part where we have the tract. We can use the tract for the second procedure. So this is the renal vein system injury. We reviewed the paper. This is the paper published in Chinese Journal of Urology from 2000 and 2017. Most of the paper published only 1 or 2 cases, but all these cases, they don't have very severe complications. The treatment for the renal vein system injury was fixed immediately. Some cases were fixed by open surgery. Some just withdraw the catheter. It is okay. And the 2 cases remove the catheter under DSA guidance. We also do the paper review on SCI paper. You can see that this is the paper published related to the renal vein injury. Seems to be most patients, this is the renal vein, this is IVC injury, but you can see that none of the cases have very severe complications. So in conclude, most of the cases who have the renal vein injury, these cases are ultrasound guided PCNL, because you know their fluoroscopy guided PCNL, it won't cause such severe complications. Most cases this is disaster what happened during the dilation procedure. The first procedure, the puncture procedure, it won't cause such a severe complication. And this is the endoscope view of the of this kind of the injury. You can see that the bleeding is very severe, and for some cases the CVP would go higher because you have some irrigations directly into the vein system. And in some time you may see the lumen, you might see the branches, but no stone. So you when you encounter this kind of cases, you should aware of that. Maybe you are injured, you get into the vein system, and you can see the wall of the vein system is white. Is not very similar to the collecting system. So summary, vein injury is rare complication during the PNL. Most of cases happen during the ultrasound guided PNL, especially in the dilation procedure. It will have severe bleeding, but if you can see that we will have a white lumen, we have branches, but no stone and severe bleeding. Fortunately, if you withdraw the sheath immediately, most of cases won't have any severe complications. That's all for my for my challenging case. Thank you.
Thank you. So I think the injury of the major vein is not quite rare in China. I heard a lot, but no very serious complications after that. Just withdraw the sheath or just involve the nephro tube and then block the nephro tube. So normally the pressure inside the vein is lower than the pressure inside the collection system. So the bleeding will stop. But 10 to 15 years ago, when I first hear about this complication, so at that time we don't know this. We think this is a very, very serious complications, and I think we can do nothing. But at that time, I remember at that time, not me, my teacher, my mentor. So at that time, he just left the nephro tube inside the major vein, and then withdraw the nephro tube slowly, maybe 1 centimeter per day, and after 1 week or 2 weeks, I forget, he finally got out the nephro tube, but nothing happened. But today we all know. Actually, we have some technique to avoid the injury of the vein. Because this only happened within the ultrasound guide. So you said about this. So we can use the fluoroscopy, but actually in China, most urologists are afraid of X-ray. So we have to change the method. So we can use the all-seeing needle. Now we have the all-seeing needle tech, and the puncture. The case you show is a full stem horn without hydronephrosis. So for such case, I think all-seeing needle will be better. We can puncture in the stone and then touch the stone, and with all-seeing needle we see the stone, and then with all-seeing needle we can go beyond the stone and light the guide wire to a safe area, maybe inside the pelvis. And at that time we can dilate safe. But actually you will see the dilation is invisible because we don't use fluoroscopy. So the next time, actually, before this, Dr. Zhang showed his invention, and now I will show my invention. Now I'm designing something can let you puncture all-seeing, and also can let you dilation all-seeing. So
we look forward to.
Yeah. So after this, the whole procedure will be visible. Everybody know before this in China, the doctors will say you use ultrasound very good. You can feel. You can feel. You can only feel, but you can't see. But now I want to change the situation. I want to make some instrument like the whole procedure can be visible by the doctors. So I wish the instrument will appear soon. So so I think if we can see anything, we can see the whole procedure. Such serious complications will never happen again. So,
thank you.
Yeah,
sorry to interrupt.
I totally double. Yeah.
Yeah, sorry, I'm just in the keeping with time, we have 5 minutes left. So unfortunately, if anyone has not been able to present their cases, we might have to pick that up on the next webinar. I'm sure Dr. Li Jun wants this to be a series of webinars, not just one discussion. We are planning to continue this conversation. And like many of you pointed out, like Dr. Li Jun and Dr. Jem, there's new inventions and new technology that might be the topic of our next webinar if you're interested. So I want to respect all the doctors' times. I know in America it's quite late. So I'd like to ask Dr. Gutierrez if you'd like to summarize our conversations.
Zach,
sorry. Yes.
Yeah,
yes.
just one comment. I think it'll take me 30 seconds. In addition to what I think the next webinar would be excellent to work on the technologies. Like I think Dr. Lee Jun, as you said, that needle you can see, and I agree. Seeing is believing, right? Another thing that we can talk about next time to avoid these kind of complications is endoscopic guided access. So in combination of multiple, we have these, single-use scopes, which are significantly reducing the cost of uteroscopy, right? We can use these digital scopes, Pusen and other companies, if you prefer. Look it up inside of the kidney and target the tip of the tip of the uteroscope to get your access, even under ultrasound or fluoro, and you know where you're going exactly. So I think those kind of things and the other devices that we talked could be excellent topic for next webinar.
Yeah, but so I think Dr. Wang still has his case, so he will show his case in a few minutes. Thank you.
Okay, sure, Dr. Wang.
Okay, hello everyone. Can you see my screen?
Yeah, clear.
Okay, so I will report my challenging case briefly. This case happened about 4 years ago. I still remember the case because I want to share this case to remind that there's a real and complicated complication for colon perforation during PCNL. This patient is male, 64 years old, and we can see the CT scan before surgery. It's a typical left renal stone, Deckhoff stone. So during the, in order to remove all as many stones as possible, we want to combine PCNL and flexible uroscope together. So we use this position, oblique spine position for this patient. The puncture is upper hole under the guidance of the ultrasound. And we are very sure the needle and the guide wire were seeing the collecting system because we just visualized in the ultrasound. So during the dilation procedure, the doctor maybe operate this procedure too violently, and after the dilation, we could see the working channel was in the colon. So we found the colon perforation just in the surgery. Because it's the first time we met this situation, so we consult many friends from the surgery department, general surgery department. Some people said that you should do the open surgery, and some people said that conservative treatment may be the first choice for this patient. So we left the drainage tube in the colon, and after that we use flexible uroscope to remove some stones. This is the CT scan after the procedure. We can see the tube was in the colon, in the ascending colon. Okay, this is the QB after the surgery. This tube, okay. Fortunately, this patient ends up have a good result. We gave the patient broad spectrum antibiotics and the bone rest for the patient. There's no very bad complications, just like intestinal obstruction, peritonitis, or high temperature fever for this patient. There's no complications. So the catheter was removed 10 days after the operation. After the discharge, we follow up the patient for 12 months and there's no complications for this patient. So we check some literatures for this problem because this is the first time we met this situation. The perforation of colon occurs about 0.3% according to the literature. And the significant risk factors were patient age and the presence of horseshoe kidney. For the treatment for this problem, most cases is extraperitoneal colon perforation. In my case, it's also extraperitoneal. So conservative treatment is the first choice for this patient. But for intraperitoneal problems, I think open surgery is needed for this patient. I also heard some report about the open surgery for the intraperitoneal colon perforation. And the risk factors for this problem, the first is retrorenal colon. Also, this patient have this problem. Previous renal surgeries, lower calcium puncture, and horseshoe kidney. These are some risk factors for this this problem. Okay, today I want to share this this case just because ball injury is extremely rare but a serious complication during PCN, and aware of risk factors for this problem might be helpful in our daily work. Okay, thank you.
Thank you.
Yeah. I want to make a couple of comments on this case before we make a closure of the session. Colon perforation, I think, is not so infrequent. I think the best way to avoid colon perforation is using an ultrasound. And sorry for my French, but this is something that you cannot see if you go endoscopically. You don't see what is around the kidney. Having the ultrasound, you see what is around your kidney. And I think, you mentioned the risk factors as a skinny patient and horseshoe kidney and all those things. The other important comment is colon perforation retroperitoneal is completely different history than doing an intraperitoneal complication. If it's intraperitoneal, the patient may die in hours. So the way you need to diagnose this is to do a CT and see, be sure that you don't have any free air in the abdomen. And if you do have, that patient need open surgery, or if you're very skillful, probably laparoscopic surgery. But the most important thing, this patient needs a colonostomy, because if you don't do a derivation of the colon, this thing is going to get open again. So that's a completely different history than the case you presented. The case you presented, I completely agree. The only thing you have to do is put independent the colon and the kidney. A kidney will be a stent, and the colon, the nephrostomy tube, will be pulled to the colon. And it closed, and probably you need to do this. I heard from one of my friends in Italy that he did a colon perforation using a mini perc, and they didn't put anything in the colon because the lesion through the colon was smaller. So probably mini perc, you don't even need to do nothing in the colon, but you need to put a drainage in the kidney, which will be, of course, a stent. It was a nice case, and I think this is a not so infrequent complication. It's infrequent, but from the injuries to adjacent organ is probably the most frequent, and it's something that is scary, but as you say, it's very easy. The management is very simple, and usually the patient got a wonderful evolution, and the need to do something else. If it's not an intraperitoneal complication, the need to do something else is very rare. So, Dr. Lee Jun, if you don't mind, let's close the session. It was very nice having this conversation with all of you. It's been an incredible discussion on the silent stone. I think I will summarize, if you allow me, probably 3 key topics from the silent stone. There is no clear consensus. What is the limit? Is 10 millimeter? Is something between 5 millimeters? Above 10 millimeters to be treated, to treat a stone, or we can do observation between 5 and 10 millimeters. So none of the guidelines are conclusive in that terms, and therefore we have been insisting that we need to think on the patient characteristics and the patient risk for a potential surgery versus observation. The other important thing that I will remark is that the number of events related to the stone, meaning pain, infection, even obstruction, may be somewhere between 25 and 70%, but the risk of treatments, intervention to remove the stone over more than 5 years may be no more than 25%. So this is something that you need to take in consideration. In addition to that, we have been saying that follow-up is very important. Consent to the patient and consent the patient, discuss with the patient what the patient wants to do. If the patient is agree and do follow-up, they need to understand the risk involved. And the other very important thing is to frequent follow-up, as we have been saying, every 6 months or every year. I think we all agree that for follow-up, an ultrasound will be enough. And in my experience, we do CT only if we are planning an intervention. If it's only follow-up because the patient doesn't want to do an intervention and you don't think an intervention is needed, I think ultrasound will be enough to do follow-up. But you need to do it every 6 months or most 1 year, no more than that. And I think all the rest of the discussion that we have had have been very, very productive, and I really enjoyed this session, and I look forward to having another webinar like this, Dr. Li Jun. Okay, thank you very much.
Thank you, and thank you, everybody.
Thank you. All right, take care. Bye-bye.
Thank you.
Bye.
All right. Thank you, everyone.
Thank you. Thank you.
Thank you.
Bye.
他们不讲了，是吧？